Okay, now let's talk about seizures here. Seizures are characterized by synchronized high-frequency neuronal firing. Synchronized and high frequency. It consists of three phases. The first one, we have the aura, which is early part of seizure may include odd smell or taste. Then you have the ictal phase, in which the time from the first symptom to the end of seizure activity, this is the whole time frame. You can call ictal phase as the full time frame. And then you have the post-ictal. After the seizure ended, it's called post-ictal, right? The period of gradual recovery back to the pre-seizure baseline level. Pre-seizure meaning normal baseline level of function of awareness. And we will talk about all these when we talk about the types. But this is just a general idea of how things are going to be looking like when they talk about aura, ictal, or post-ictal. Now let's take a look at focal seizures. Focal seizures, it consists of, it originates in the single. Again, focal means just originate from one area of the brain, right? A single area of the brain is focal, versus generalized is diffuse. It's generalized. So focal, one area, single area of the brain. Most commonly, what is the most common location? Let me erase this part. Most common location is medial temporal lobe. Types are, you have a focal aware and focal impaired awareness. In focal aware, we formally call simple partial. There's a consciousness which is intact, and there's a picture at the bottom which will help us a lot. But just to read this, let's just read it and we look at a picture. Consciousness is intact, 100%. There's a motor, sensory, autonomic, or psychic symptoms will be present, versus your focal impaired awareness, which is called partial but complex seizures. It is impaired consciousness. So difference is only consciousness is impaired versus consciousness is preserved. And you have automatisms. Automatisms are also there. Here in focal seizures, we also are going to be looking at epilepsy, which is a disorder of recurrent, important is the recurrent unprovoked seizures. Febrile seizures are not epilepsy. Okay. Convulsions, convulsive status epilepticus. It is a continuous greater than 5 minutes or recurring seizures without interreactal return to the baseline of the consciousness that may result in the brain injury. So greater than 5 minutes, you're going to the brain injury. Causes of seizures by age, for example, in children less than 18, you're going to have causes are genetic infections, febrile seizures, trauma, congenital metabolic, adults, tumor, trauma, stroke infections, or old age. You're looking at strokes, again, tumor, trauma, metabolic, or infectious. On the other hand, you also have psychogenic non-epileptic events, which resemble prolonged greater than 1 minute syncopal or tonic-clonic episodes without the post-ictal phase. Autonomic disturbances or tongue biting, often witnessed with vocalizations and preceding aura. Let's actually take a look at picture and then we will come back to it because it's going to make sense when we look at the picture itself. So we have a seizure, right? We said it could be focal or it could be generalized. Let's take a look at the focal ones. For the focal ones, all we have is, we will ask the question, does the patient has impaired consciousness or not? Is the consciousness present or is there impaired consciousness? So impaired consciousness is there, meaning there is loss of consciousness. Then you will just call it complex partial, which is the other name, focal impaired awareness, right? Because that patient lost the consciousness, right? And if the patient did not lose consciousness, then you will just call it focal aware seizure, which is, in other words, simple seizure, right? So one thing we are going to look at, let me just write it down here, is loss of consciousness. LOC, loss of consciousness. So loss of consciousness is not here, but yes here. And one other thing which we will see is the post-ictal phase. Is there a post-ictal phase? When the patient did not even lose consciousness, how is going to have a post-ictal phase? Of course not, right? With loss of consciousness, yes, you're going to have a post-ictal phase, okay? And we will compare that with the other ones. But just to now remind up top, we talked about consciousness preserved versus consciousness impaired. Simple that. Okay. And it is originated from a single area. Now let's look at changing color here. Generalized. Generalized is for diffuse type because it's generalized. What are the types? We have the absence, myoclonic, tonic-clonic, tonic, atonic, atonic. So absence is called petit mal, which is about 3 heart spike and wave discharge on EEG, short, usually 10 seconds. Again, absence is what? This is important, is usually 10 seconds. Frequent episodes of blank stare, important. The patient will present of 10 seconds episode with blank stare, possibly automatisms, no postictal confusion, can be triggered by hyperventilation. Let's take a look at absence now. Here is the absence. If you look at the generalized at the very end, which is known as petit mal. Here, look at this patient, blank stare. No, because it's there's a blank stare with no post-ictal confusion. After the seizure activity of less than 10 seconds is gone, they're not going to have that confusion of after the seizure is gone. So just they will have a blank stare for they're saying less than 10 seconds. In some area they say less than 20 seconds. So just think about seconds here. Some seconds of blank stare and nothing else for this absence seizures. Okay. Then you have the let me highlight this, myoclonic. Myoclonic is quick, repetitive jerks, no loss of consciousness, or even post-ictal confusion. Here's the myoclonic. Look at the patient here, sort of a thing here. So what do you see? You see repetitive jerks, quick and repetitive jerky movements, myoclonic. But the problem with this is, even though you're jerking, but there is going to be no loss of consciousness. So let's just do it here. So we're going to take a look at these two. Okay, let me erase this. So this guy go up top. Okay, so no loss of consciousness and no postictal state. Important. Okay, let's take a look at the next one, which is tonic-clonic, which is known as grand mal. It is alternating stiffness and movement. There is going to be a post-ictal confusion. Important. There is going to be urine incontinence, tongue biting. Okay, all of that are important. So just take a look at tonic-clonic. This is the tonic-clonic, which is known as grand mal. You have a tonic phase and an aclonic phase. That's why the name is tonic-clonic seizures. But on top of that, importantly, you have loss of consciousness. You have post-ictal state. You have tongue biting. You have urine incontinence. Okay, that is going to be there. So if you look at the tonic, the patient goes into this tonic phase and the clonic phase. So you have a diffuse. So the patient undergoes into this. So they have, wait, here. There's a diffuse muscle contraction. Okay, and followed by rhythmic jerking. Okay, followed by rhythmic jerking. So tonic-clonic phase. Let's take a look at the next one, which is called tonic. Again, stiffening is tonic. In the tonic one, all you have is just the stiffening. Okay, there is no rhythmic contraction and relaxation. It's just stiffened. The patient will be stiffened up. And the next is all about atonic, meaning drop seizures, falls to the floor, commonly mistaken for fainting. So the patient had a faint, a patient had a seizure, but you think about fainting. Fainting is like when you have a syncope, you drop to the floor, So here is just the atonic, meaning there's a drop seizure. The patient drops to the floor. So you would say, oh, it may be that is due to some syncope. A syncopal episode was there, but it's due to actually atonic seizure, which is just the patient will fall right away to the floor. And that's right here, atonic, drops, seizure, falls to the floor. Okay. So now important thing in all of this is also about treatment, which they haven't mentioned. So let's just talk about that here since we are looking at this picture. So the treatment for all of these are going to be So for focal aware seizures, you can give a narrow spectrum and anti-epileptic medication. For example, carbamazepine, phenytoin. But you look, you have a range of medications here because it's a focal seizure, not a big deal. I mean, everything is a big deal, but you have a range of medications to treat this. Phenytoin, lamotrigine, and levetiracetam. So lamotrigine and levetiracetam, all of them. But these two, the first two, which was the carbamazepine and the phenytoin, they are your narrow spectrum. Okay, and you can utilize all of them for these focal seizures. Now, things go specific when we go into tonic-clonic seizures. So the best drug to go for this is levetiracetam. And this is also going to come in pharmacology, but this is important to just knock it down here. So we don't even have to think about, or all we will look at is mechanism of actions. And for this myotonic seizure, the drug of choice is going to be valproic acid. And for absent seizures, the drug of choice is going to be your ethosuximide. Or second line, you can add this valproic acid. Okay, so, and then let's just take a look at the psychogenic non-epileptic events. Here, let's just erase all this and then look at in a simple way. Psychogenic non-epileptic events, they resemble greater than 1 minute simple or tonic-clonic episodes without post-ictal phase. So there is no post-ictal phase. You would see autonomic disturbances or tongue biting, often witnessed with vocalizations and preceding aura. So aura is there. Female sex predominance, risk factors or history of psychiatric disorder, substance use or normal video EEG. Okay. There's something also known as juvenile myoclonic epilepsy. I don't know if they mentioned that. Let's just talk about that as well here. It's called juvenile myoclonic epilepsy. They did mention epilepsy up top, so that one of the in the juvenile cases, like in children. So in this, all you have is myoclonic seizures. So myoclonic seizures within 1 hour of activity, prolonged by sleep deprivation. So again, myoclonic seizures within 1 hour after waking up. So it is associated with sleep, and it would increase. You're increasing the risk provoked by sleep deprivation. And that is going to be for GME, and it's juvenile myoclonic epilepsy. All right, let's just review this. Here we have seizures are characterized by synchronized high-frequency neuronal firing. They have considered 3 phases. Aura, you know that aura could be anything. Before the early part of seizure, you can have the aura before you get the seizure. Then you have the ictal phase, which is the time from the time from the first symptoms to the end of seizure activity, like it's the ictal phase. And then the post-ictal after the seizure. What is the gradual recovery back to the pre-seizure baseline level of the consciousness or awareness post-ictal after the seizure, right? So we have types of seizure: focal, and generalized. Focal originates from the single area, meaning only the one hemisphere of the body, of the brain actually, right? Most commonly, the high yield point is medial temporal lobe is going to be the area which it would originate from. And in case you have here, you would have hippocampus and amygdala. And focal aware, all you have is the consciousness is intact, and you can see all the other symptoms like motor, sensory, autonomic, and psychic symptoms. Where the focal impaired, you have impaired of the consciousness with automatisms, which are lip smackings. And then you have this generalized. With the generalized, all we are going to be thinking about is, first of all, the absence seizures. Absence is with the diagnostic test, you have a 3-heart spike in the EEG. Okay, it is usually less than 10 or 20 seconds with the loss of consciousness, meaning at this time when they are in an absence seizures, no tactile, no verbal stimulation will, they will be unresponsive. The patient will be unresponsive to any tactile or verbal stimulation. Frequent episodes of they will go into a blank stare with possible automatisms again, with no post-ictal confusion after they are back up into the normal state. They're not confused. They know where they're at. Everything is pretty normal. Other than that, it could be triggered by important thing, hyperventilation. With a child having this absence seizures, a child would not go into any other seizures. There is no risk for the absence seizure to go into any other type, in which case you have the generalized tonic-clonic or myoclonic seizure. But in older children, for example, 10 to 12 years, or after 10 years, you can think about that. They will go. There is a propensity for them to go into myoclonic or tonic-clonic, generalized tonic-clonic seizures. The second one here we have is the myotonic. Myotonic is all about, if you take a look at this picture, it's about quick repetitive jerks. Again, quick repetitive jerks with no loss of consciousness, important, or post-ictal confusion. So that's why we have put here no, meaning there is no loss of consciousness and there is no post-ictal space. Compare this with the tonic-clonic. Tonic-clonic seizure will give you a loss of consciousness, will give you post-ictal state, which is right here. Alternating stiffening and movement. Post-ictal confusion is there. Urinary incontinence is there. Tongue biting is there. And then you have this tonic is all about stiffening, and atonic it looks like fainting, but it's not. It's an atonic seizure. On the other hand, we have epilepsy. Let's change color to that. Epilepsy is all about recurrent unprovoked seizure. For example, in case of febrile seizure, a child who develops fever, it's going to impair the hippocampus. Hippocampus, when it's impaired, leads to febrile seizures. And febrile seizures are not epilepsy. That's high yield point. They're not epilepsy. What is epilepsy? Recurrent unprovoked. But we talked about being a febrile seizure, which is provoked by fever. So whatever is, if you have a provoking factor, it's not going to be an epilepsy. Epilepsy is all about unprovoked. There is no provoking thing, and that's called epilepsy. Then you have the convulsive status epilepticus. Here you're looking at continuous seizures which are recurrent without any coming back to the consciousness, without fully regaining consciousness. The patient will not go back into the consciousness within the episodes, between the episodes, and that would generally result in brain injury. And the treatment would be for these guys. The treatment would be your IV benzos, like for example lorazepam plus phenytoin. This phenytoin would prevent the reoccurrence of status epilepticus. That is a high yield point. Now, here are some categories of seizures by age. In children, you genetic and all that. So, because in children, you're going to think about genetic, but as you go older, you're talking about tumor, trauma, and infection, metabolic, all that scenario. But here, then you have these psychogenic non-epileptic events. They resemble prolonged syncopal or tonic-clonic episode without post-ictal phase or tongue biting, or even autonomic disturbances, often witnessed with vocalizations and preceding aura. So all they have is just the aura there. Female sex predominance risk factors are psychiatric disorder. If the patient has some psychiatric disorder, for example, female sex, you will think about something known as psychogenic non-epileptic events. Normal video EEGs will be there. Now, importantly, looking at this one, all we have here is about focal. Focal, you have a simple, in which case you don't have loss of consciousness. With focal, if you impair the consciousness, it's called focal impaired consciousness, or in other words, awareness. You will not have because you didn't lose consciousness, you're not going to have a post-ictal state, right? And because you lost the consciousness in the first one, you will have post-ictal state. Other than that, you have generalized. In generalized, you're looking at a couple things. Importantly, let's talk about the first one here, the myoclonic. In the myoclonic, all you have is this movements, right? Nothing, no loss of consciousness or no post-ictal state. But compare this with the tonic-clonic, which is known as grand mal seizures. Here you are going to have a loss of consciousness and loss of, there is going to be a postictal state. Here you're going to have alternating movements, stiffening and movements. And the treatment for the grand mal is going to be levetiracetam, which is a broad spectrum anticonvulsant. And for myotonic, it's going to be the valproic acid. Both of these are broad spectrum anticonvulsant. For the focal, you want to go with narrow spectrum and anticonvulsant, for example, carbamazepine and phenytoin. And for high yield point for absence seizure is going to be something called as treatment is ethosuximide, high yield. And the second line drug, if ethosuximide is not fixing the problem, then you can go with valproic acid as a second line drug. But here again, you with this absent mal, the patient is going into blank stare with loss of consciousness for about less than 20 seconds. And in that period, they will not be able to respond to any tactile or verbal stimulations. And that is going to be all for seizures. Okay, now let's talk about headaches. Here, headache is just a pain due to irritation of intra or extra cranial structures. For example, meninges, blood vessels. Primary headache includes tension type. That's the first one. You have the migraine. You have the cluster. Secondary headaches include medication overuse, meningitis, subarachnoid hemorrhage, hydrocephalus, neoplasia, giant cell arteritis. So let's talk about the first one, which is tension type headache. Tension type headache, important thing is how they are localized. So tension type headache is just bilateral. Look at the picture, bilateral localization. Duration is going to be greater than 30 minutes, typically 4 to 6 hours constant, meaning duration has to be greater than 30 minutes. It typically is for about 4 to 6 hours and a constant headache. Okay. Other important factors you could have they're associated with they're associated with stress or fatigue. So fatigue or stress, as the name suggests, tension, stress, all that. They are not disabling. Important. They are headaches, but they will not disable the normal functioning, so not disabling. Now let's look at the description here. They are steady band-like, as the band is there, band-like, no nausea, vomiting, no more than one of the photophobia or phonophobia. Again, what is phonophobia? Photophobia is sensitivity to the light, right? So phonophobia is fear of the loud sounds. Phonophobia, fear of loud sounds, sound fear. There is no aura. Most common primary headaches, more common in females. What are the treatments for this tension type headaches? Acutely, you can give analgesics, NSAID, acetaminophen. Prophylactically, you can give TCAs, example, amitriptyline, and behavioral therapy. Okay, take a look at the second one. We have migraines. Migraines are unilateral. Look at this unilateral pain. Duration is going to be about from 4 hours to 72 hours. That's a lot of pain for so much time, right? Here is going to be, the description is going to be pulsating. The other word is throbbing, pulsating pain with nausea, with photophobia. Again, if you look up top, all you had is no more than one of the photophobia or phenophobia. Here you have nausea. Up top, you didn't have no nausea, no vomiting. Here you have nausea, you have photophobia. Plus, you can just think about phonophobia also there. May have plus aura. There was no aura up top. Here you have aura. Due to irritation. Why this happened? Due to irritation of CN5, granular 5, meninges or blood vessels, which cause the release of vasoactive neuropeptides, important, high yield. Example, substance P, high yield, calcitonin gene-related peptide. Also there, so you have calcitonin P and, substance P and calcitonin gene-related peptide also being there. More common in females. Again, females are the more commonly occurs in the females. The mnemonic they have is the POUND, which is pulsatile, 1-day, unilateral, nausea, disabling. So this migraines are disabling type of headaches. Treatment is also very important. NSAIDs, triptans, and dihydroergotamine, antiemetic, for example, prochlorperazine, metoclopramide. Prophylaxis is also high yield, in which case you have lifestyle changes, example, sleep, exercise, diet, beta blockers, amitriptyline, topiramate, valproate, botulism toxin, So because it was one of the things causing it, so you want to give anti-CGRP, which is calcitonin gene-related peptide, and also monoclonal antibodies. Okay, so here, let's just write some extra stuff here. High yield points are, they are going to be, because there's aura there, so they're also related to some food, emotions, even menstrual cycle, food, emotions, menstrual cycle, and plus minus, they would have a family history positive, could be there, plus minus, all right? And what is aura basically? It's about, if you eat, important point, very high yield. Aura could be positive or negative. Positive or negative. So the positive aura is all about, like, for example, bright spots they will see. They will hear some noises, or paresthesias or movements. Versus, so let me just write a couple. So bright spots, noises, paresthesias, or movements. With the negative aura is all about vision, hearing, sensation loss. They might go into vision, hearing, sensation loss. That's a negative aura. But they're all associated with migraines. Okay, here, so let's take a look at actual thing about this pathology here. So we said it is due to irritation of CN5, or the meninges, or the blood vessels, with the release of vasoactive neuropeptides. So these vasoactive neuropeptides are the vasodilators. They are the vasodilators. So vasodilation leads to extravasation of fluid, and that extravasation of fluid would irritate the meninges. Irritate the meninges and leads to migraine. So irritate meninges leads to migraine, right? So the treatment would be that you would inhibit. I mean, if it is due to the fact that if you are, the whole thing is caused by these vasoactive peptides, so you want to inhibit these vasoactive peptides by giving, either by giving vasoactive peptide inhibitors, for example, right here, anti-CGRPs, or and cause vasoconstriction. When you inhibit these, leads to vasoconstriction, and that's what we're looking for. Other than that, you also have diargotamines, triptans, diargotamines. Here you can, for the diargotamines, it works on your serotonin receptor. It's a serotonin agonist, and alpha-1 receptor partial agonist. The important thing with the antiemetic, if you're giving these drugs, for example, let me erase some points here because I messed up the coloring. But here, the antiemetic, for example, prochlorperazine and metoclopramide, you have to think about an EPS, sign and symptoms, extrapyramidal sign and symptoms, as the adverse effects. Now the prophylaxis, who can we give the prophylaxis to? If there are 3 attacks per month, then you look for prophylaxis. If 3 attacks per month, then you go into prophylactically giving them drug prophylactically. For example, lifetime change is one important thing. Amitriptyline, topiramate, valproate. This topiramide, let's just do this. Amitriptyline is a TCA, tricyclic antipsychotic drug. Beta blocker, you already know. With the topiramate, valproate is all about these are anticonvulsants. Botulinum toxin, anti-CCP is going to inhibit that CCP. Monoclonal antibody is also there. So if you look at the prophylaxis, they're not normal. They're like pretty high drugs. that you're giving, and that is important. And that's going to be all for this migraine. Let's look at the cluster headache. For the cluster headache, we have, let's change color, cluster headache. Cluster headache is unilateral, again, which was also unilateral, migraine. Cluster headache is also unilateral. But here the time frame is very, from 15 minutes to 3 hours, and there's a repetitive pain, okay? It is going to be, high yield is periorbital pain, excruciating periorbital pain with autonomic symptoms. For example, high yield. So this guy's like crying out of the pain, crying. With that cry, it goes into rhinorrhea. It causes rhinorrhea, lacrimation, conjunctival injection, the redness of the eye, the conjunctiva, right? May present with Horner syndrome, more common in males. So this guy got a punch. Just think about it. The guy got a punch on the eye. Now he's just crying like a baby, okay? And I mean, he's a baby, of course, but he's just crying. One side pain, only one eye pain with conjunctival injections, meaning redness of the conjunctiva, all that. And also on top of that, you have lacrimation, rhinorrhea with a periorbital pain, just periorbital pain and nothing else. With the treatment, you can give sumatriptan, 100% O2 can be the treatment. Prophylaxis is verapamil. And why do we have this? The question might arise, why do we have autonomic symptoms like lacrimation, rhinorrhea, conjunctival injection? We have it due to PNS hyperactivity, due to parasympathetic PNS, parasympathetic nervous system hyperactivity, which causes all this lacrimation, rhinorrhea, conjunctival infusion, and it could also present with Horner. So how is the Horner syndrome going to present? Ptosis, meiosis, and anhidrosis, right? Ptosis, meiosis, and anhidrosis. Okay, and that is going to be all for this one. Let's take a look at now trigeminal neuralgia. So trigeminal neuralgia, it's the recurrent brief episodes of intense unilateral pain. Again, if you look here, it's a unilateral pain with the cranial nerve 5 distribution. Usually, they're saying, although they're usually only V2 and V3 are affected, meaning just this part. Okay. In most cases are due to compression of the V and 5 root by an aberrant vascular loop. Pain is described as high-yield electric shock-like stabbing pain. Electric shock-like or stabbing pain usually lasts for seconds, typically triggered by high-yield. Light, you touch it lightly, they're going to have an electric shock-like pain and stabbing pain. With the light touch or facial movements like chewing, like talking. Again, treatment is again high yield, which is carbamazepine, or you can also give oxcarbazepine. But this is what you have as an important factor. Other things that you can also have as far as the trigger is concerned, shaving, exposed to hot temperatures, brushing teeth, and swallowing. So anything that messes up with the cranial nerve 5 is going to give you electric shock like stabbing pain. The patient classically, one more thing, let's just talk about that as well. So classically, the patient will say, feeling as if the knife is being stuck into the face. So patient will say, okay, classically, you have the patient will feel like a knife is being stuck into the face. So just imagine how painful that would be if a knife gets stuck into the face, right? And that's the sort of pain they will experience. All right, now let's talk about these secondary headaches. Okay, secondary headaches. Let's look at the first one here: subarachnoid hemorrhage. Subarachnoid hemorrhage is going to present with sudden severe headache, the worst headache of my life, right? That sort of a scenario, worst headache of my life. with a sudden, again, the important wording is sudden headache, right away, sudden headache, with neck stiffening, photophobias, and loss of consciousness in about 50% of the patients. There is going to be a loss of consciousness. That's the subarachnoid hemorrhage. Okay. Other than that, you would also think about some things. Let's just erase this part and talk about, we talked about subarachnoid. Now, the second thing you can also think about is called pseudotumor cerebri. Pseudotumor cerebri, that is going to be risk factors. There are a couple of risk factors for pseudotumor cerebri. Other words, the other thing is idiopathic intracranial hypertension, idiopathic intracranial HDN hypertension. And the risk factors are going to be obese patient, or OCP use in females, in young women. Importantly, when you look at their do the phonoscopy, you will see papilledema. You will see papilledema, headache, and increased cranial. So let's just write here these couple of factors. You will have check their phonoscope. You will see papilledema. Again, you will have increase in intracranial pressure, and it's going to give, of course, headache for sure. That's what we're talking about, secondary headaches here, right? And also, it's going to give you CN6 palsy. CXN palsy. And if you recall, what is CN6 palsy? Cranial nerve 6 is the LR6, right? A lateral rectus. So it's going to cause diplopia. Okay. And that is going to be with pseudotumor cerebri. Other than, let's talk about some more. Let's actually go down and talk about them. One of the things you will also see is acute sinusitis will also give you headache. Acute sinusitis, high yield point with the acute sinusitis is they will have, again, with the sinusitis being their runny nose, sore throat, headache. With high yield point is headache that occurs when they bend forward. When the patient moves forward or bend forward, they will have headache would worsen at that time. Headache worsen with bending forward. Okay, that is with the acute sinusitis. Painful palpation of the, again, frontal or maxillary sinuses. There might also have been, but important high yield point was all about headache while being bending forward. Other than that, we have to look at this. Let's go back. What are the other options? Hydrocephalus. Hydrocephalus is because you're increasing ICP, intracranial pressure, because of the blockade, and that's going to cause irritate the meninges, again, cause meningitis sort of a pain. So what is the meningitis sort of a pain? Meningitis sort of pain is headache. Let's just write it here. Headache, neck stiffness, photophobia, fever. But with the meningitis being there, meningitis itself, you will see ill contacts and rash with the meningitis, okay? Neoplasias. Neoplasia is the next category here. Neoplasia are going to be your space occupying lesions on imaging. You will have focal space occupying lesion for sure, and also on top of that you will have papilledema and morning headaches with these neoplasia type of headaches, with nausea, vomiting, of course, there. And joint cell temporal arteritis. It's about, let's just write that one here. I have pretty much whole page. Let's just erase some things. Talk about the giant cell, which is also known as temporal arteritis. Giant cell temporal arteritis would classically going to present with jaw claudication, with visual disturbances. So jaw claudication, visual disturbance, and tenderness, high yield, because it's giant cell temporal. So tenderness, meaning when you touch it, they will have the pain. They don't have a pain, but as soon as you touch the temporal area, they're gonna have a pain. It's called tenderness, right? So tenderness of the temporal area, tenderness of temporal area. And other systemic sinus symptoms could also be present, like muscle pain, fatigue, and weakness. Treatment for joint cell arteritis is also high yield, and that is going to be prednisolone. Okay, and that is going to be there for this. That's all for the giant cell temporal arteritis. And do we have anything extra here? Now, important point for this tension headache, I just noticed that. Let's just talk about that as well. With this cluster headache, one more thing is opioid withdrawal. Opioid withdrawals. They also cause lacrimation, rhinorrhea, diaphoresis. But look, what are we looking at? Lacrimation, rhinorrhea, everything we see with the cluster headache, with the pain headache on top, right? But here, it's going to be, with opioid withdrawal, it's going to be bilateral pain. But here in the cluster, you just have unilateral. That's the differentiating feature here. But on top of that, with the opioid, you will also have some GI symptoms like diarrhea, nausea, vomiting, and mydriasis. Okay, but that's one of the important things to mention. And that's all for headache. Let's just quickly go over these. Okay, review. We have headache. Headache is all about irritation of meninges or the blood vessels. They are either the primary, which are all of these, or either the secondary, which are all of these. So let's take a look at the primary. The tension type is a band-like bilateral. So only one which is bilateral is going to be your tension type, which is a band-like pain, okay, without any nausea, vomiting, or with any aura being there. It is the most common, and it is just a normal headache without any disabling feature, not disabling basically, right? And you could just treat it with normal thing. For example, analgesic and acetaminophen. Prophylaxis, if you want to go for it, is TCA. Example, amitriptyline or behavioral therapy. With the migraine, is all about unilateral. Even the cluster is unilateral. Everything else you're going to look at is going to be unilateral pain. So with the migraines, you are looking at 4 to 72 hours of pulsating, throbbing pain with nausea, phonophobia, aura. It is all due to irritation of the CN5 or the meninges or the blood vessels. So we added a new thing here, CN5. Okay, there is a release of high yield, release of vasodilators, vasoactive neuropeptides, which are substance P or CGRP, more common in females. So here the mnemonic is POUND, which is pulsatile 1-day unilateral nausea disabling. Again, treatment is NSAID, but add triptans or dihydroergotamines or antiemetics, or if you have 3 attacks per month or 3 attacks per month, you can go for prophylaxis, which is beta blocker, amitriptyline, or your anticonvulsants or anti-CGRPs, botulinum toxin, or monoclonal antibodies. With a cluster headache, it's all about unilateral one eye pain, which is periorbital pain. When you have a pain in the orbit, around the orbit, you're going to cause autonomic symptoms, lacrimation, rhinorrhea, conjunctival ingestion. Also, Horner syndrome could also be there, ptosis, meiosis, anhidrosis, right? And the treatment is sumatriptan or 100% O2. Prophylaxis is verapamil, which is what? Calcium channel blocker. And that is going to be all for these headaches. Now looking at the trigeminal neuralgia, it is the recurrent brief episodes of intense unilateral pain of, again, cranial 5 distribution within V2, V3. Most common. So whatever is going to touch this area is going to have an electric shock like stabbing pain, which is triggered by, again, light facial touch, facial movements, chewing, talking, shaving, swallowing, anything. High yield, the treatment is carbamazepine. Okay. Other secondary tumors are subarachnoid hemorrhage, worst headache of my life with meningitis sign and symptoms, hydrocephalus, increasing ICP, causing irritation of meninges, causing, again, meningitis sign and symptoms. Neoplasia will give you space-occupying lesion on imaging, space-occupying lesion, plus papilledema because of increase in ICP. Joint cell arteritis, again, is going to give you, joint cell arteritis is going to give you jaw claudication with tenderness on the temporal area, important. Okay, And meningitis is all about just headache, neck stiffness, photophobia, fever. With specific meningitis, you're looking at rash or ill contacts, and that is going to be all for this. Okay, now let's talk about dyskinesia. Dyskinesias are all movement disorders. Let's take a look at the first one. We have akathisia. Akathisia, the presentation with akathisia is restlessness and intense urge to move. Notes can be seen with neuroleptic use or as an adverse effect of Parkinson's disease treatment. So where do we see akathisia, which is restlessness, intense urge to move, with the Parkinson's disease treatment with neuroleptic use. Then you have the next one is asterexis. Asterexis is again with the flapping motion upon extension of wrists. So flapping of the wrists is called asterexis, which is associated with hepatic encephalopathy, also Wilson disease, and other metabolic derangements, which causes asterexis. Okay, and then you have the athetosis. We talked about this athetosis in Korea, so let's just take a look at here. Athetosis is slow, snake-like, wriggling movements, especially seen in the fingers, caused by a lesion to the basal ganglia, seen in where Huntington disease. With the chorea, we have it as going to be sudden, jerky, purposeless movements. Chorea equals a Greek word for dancing, caused by lesion in the basal ganglia, and also seen in the Huntington disease, and acute rheumatic fever, high-yield acute rheumatic fever, which is Sydenham chorea. Okay, here one of the important points with the chorea is going to be these could be the movements of just the face and the extremities, and these movements that flows from one muscle to another. So these movements will flow from one muscle, group to another group, and that's why it's dancing, because dancings are properly organized sort of movements, right? So then you have this dystonia. Dystonia is all about sustained involuntary muscle contraction. That you just have a sustained involuntary muscle contraction. For example, in writer's cramp, blepharospasms, torticollis. Okay, and this is also very high yield. That let's just talk about this dystonias here. You can have a focal dystonia. A focal dystonia is again involves one major or one group of muscles. Examples are again your writer's cramp, in which examples of writer's cramps are blepharospasms, which is involuntary forcible closure of the eyelids. Involuntary forceful closure of eyelids. And then you have this, if you have a cervical dystonia, that is called spasmodic torticollis, cervical dystonia, which is torticollis. Okay. So here all you have is just, again, it's a focal, it's going to be a sustained contraction. That contraction, you will not relieve that contraction. It's a sustained contraction, which forces the certain parts of the body into abnormal, sometimes painful movements or the postures. So even with this thing, dystonia being there, it can cause pain because certain movements are going to be painful or certain postures are going to be painful. So it can lead to pain with sustained contractions. Then you have this. The next thing is called essential tremors. Essential tremor is the high frequency tremor with sustained posture. For example, outstretched arms worsen with movement or anxiety. So essential tremor is going to worsen with movement. They're also known as familial. So essential tremors are also called familial tremors. And the differentiating feature, this versus the other ones, are going to be these are going to occur at both the rest and intention. So they will occur at rest plus intention of something. Let's say you're trying to grab something, you will get the tremor. But on top of that, you also have it in the rest as well, plus intention. So they are familial, mentioned there. Patients often self-medicate with alcohol. So important, alcohol would decrease the tremor amplitude. Or you can also treat them by giving non-selective beta blocker, like propranolol or barbiturates, primidone. So propranolol, commonly used for familial tremor, essential tremors. Now looking at the next one, is called intention tremors. As the name suggests, is the intention, right? With the you can get with the a tremor with the intention. For example, slow zigzag motion when pointing, extending towards a target. When you're going towards a target, you are going to get a slow zigzag tremor, which is caused by what? Cerebellar dysfunction. Cerebellar dysfunction. Again, if you take a look at this one, it's going to be, again, involuntary sudden movement, right? And you have movements of the limbs ipsilaterally. Cerebellar dysfunction. So let's compare these two together. What did we learn? Essential is going to be high yield, rest, and intention. With the intention is only add when you're going towards a target, you're going to get the tremor. With the essential is just familial, without any problem anywhere. With the intention, there is a problem in the cerebellum. Okay, let's move on with the resting now. Resting tremor, again, as the name suggests, resting, it is uncontrolled movement of distal appendages, and most noticeable in hands. So when the hands are resting, they are going to do tremor. So tremor is alleviated by intentional movement. So while you're resting, you have tremor, but as soon as you initiate a movement, you're not going to have a tremor. That tremor would stop. This is seen where in Parkinsonism or in Parkinson disease. It is caused by lesion in substantia nigra. Substantia nigra occurs at rest, which is going to be pill rolling tremor of Parkinson disease. When you park your car, it is at rest. This is a mnemonic that if you park, meaning Parkinson, you can have a resting tremor. That's actually a good mnemonic. If you park your car, it is at rest. Park mean Parkinson, rest mean resting tremor. Then you have this hemiballismus. Hemiballismus is a sudden wild flailing of one side of the body. Okay, sudden white flailing of the flailing movements. For example, what are they? So they are going to be your movements of proximal limb. For example, arms and legs ipsilaterally. So proximal limbs of could be your arms or legs. So arms are proximal and legs are proximal, right? Not the forearm, right? So arm is proximal, and they will have ipsilateral movements of one side of the body only. That's why I'm saying ipsilateral. They're caused by lesion to the contralateral subthalamic nuclei. So that's important. Contralateral, where subthalamic nuclei due to lacunar stroke. Lacunar stroke, right? And if you recall lacunar stroke, what was that all about? For example, if you have a long-standing hypertension or diabetes, you are going to cause a lacunar stroke, which would damage your subthalamic nuclei, which would lead to hemiballismus. Their mnemonic is, let's take a look at the mnemonic. In hemiballismus, half of the body is going ballistic. Hemi, half, right? Ballismus, ballistic while flailing movement of the body. Okay. Then you have myoclonus. Well, a myoclonus is a sudden, brief, uncontrolled muscle contraction, right? It is jerks, hiccups, common in metabolic abnormalities, for example, renal liver failure or Creutzfeldt-Jakob disease. And this is all about your myoclonus. So they're also seen with epilepsy, okay, myoclonus. And it's also one thing called hypnopic jerks. If you have, I don't know if you have seen this one, but it's called hypnopic or something, hypnopic jerks, which when you're trying to sleep occurs when falling asleep. There's some jerky movement that you feel like it happened, but while you're trying to fall asleep, that's called hypnopic jerky movements, which is again myoclonus when you're trying to fall asleep. Okay. What else you might be there? They're also known as atypical jerks, but they're all physiological. These are also known as atypical jerks. They're all physiological when the person is trying to fall asleep. And importantly, when would they occur? They will occur where in the N1 in the sleep cycle, non-REM sleep N1 cycle. And that is going to be all for this. Let's take a look at the last portion here, which is restless legs syndrome. Restless leg syndrome, it is uncomfortable sensation in legs causing irresistible urge to move them. So you have a sensation in the legs that will cause you to move the legs. Emerge during the periods of inactivity, most prominent in the evening or at night, transiently relieved by movements. So when you move, that uncomfortable sensation will be relieved. For example, if you try to move while walking or moving the leg, right? Usually they are idiopathic, often with genetic predisposition, may be associated with iron deficiency. Now these are important. Iron deficiency, CKD, chronic kidney disease, diabetes, especially with neuropathy. Treatments are gabapentinoids, dopamine agonists. So it's a pretty simple thing. Restless, meaning there is a problem in the leg syndrome, that there is an uncomfortable sensation that would urge you to move the leg. Normally occurs at the evening or night. It is associated, meaning if somebody has this, it is highly likely that they might be having a iron deficiency, CKD, diabetes, a neuropathy. So the treatment would be gabapentinoids or dopamine agonists. With the CKD, you're thinking about uremia, which is causing it, okay? And that is all for movement disorders. Let's actually talk about one last thing here. It's called myotonia. Myotonia. We talked about myoclonus, but not myotonia. So myotonia is, again, sustained muscle contraction. Sustained muscle contraction. For example, it is seen in, for example, let's give you an example first, then I'll talk about what is seen. The patient would not be able to, they cannot release a handshake, high yield thing here. A patient will not be able to release a handshake. And that is seen with what disease? Myotonic muscular dystrophy. It's seen in, it will be in your biochem section. Myotonic muscular dystrophy. Can't release handshake. They have a handshake, they have a hard time releasing that. And that is the myotonia. And that is all for this section. Let's move on to next. Okay, now let's talk about neurodegenerative movement disorders. There are the Parkinson disease and Huntington disease. Okay, so let's look at the first one, Parkinson disease. Parkinson disease, there's a loss of dopaminergic neurons in the substantia nigra pars compacta. Depigmentation. Now, taking a look here in picture A, you have a normal, you can see it's a, let's actually zoom in first. You see there's a pigment, pigmentation here. But in Parkinson disease, you don't even have that pigmentation anymore. It's called depigmentation. So going back, there is the loss of dopaminergic neuron in substantia nigra pars compacta, and you will see the depigmentation there. Symptoms typically manifest at age after age 60, and the mnemonic is body trap, which is going to be T for tremors, specifically pill rolling tremor at rest. So tremors at rest. Rigidity, cogwheel lead pipe rigidity, which is basically a cogwheel lead pipe rigidity is all about let's just do it here, rigidity on passive flexion or extension. So it's really the limbs are going to be rigid when you try to flex them passively, meaning you're doing it to the patient. Passive flexion extension is going to be rigid on the extremities. That's called cogwheel lead pipe rigidity. And then you have this akinesia or bradykinesia, which is shuffling gait, small handwriting, micrographia. Okay. So what is akinesia? Akinesia is they will not be able to initiate the movement. Bradykinesia is a slow movement. So again, shuffling gait, small handwriting, micrographia will be seen. Okay. Then you have the postural instability, which is tendency to fall. Because why? Why would they have a tendency to fall? Due to orthostatic hypotension. So they have orthostatic hypotension, which causes a postural instability. As soon as they get up, they have the tendency to fall. Okay. And that is known as another word, but not important. That's called Shy-Drager syndrome. Shy-Drager syndrome, which is predominantly you will see postural instability in a Parkinson disease. That's called Shy-Drager syndrome, but that's not that of important. What is important is the strap, tremors, rigidity, akinesia, and postural instability. Okay. Dementia is usually high yield. It is a late finding in Parkinson disease. So PD has a dementia, but it's a very late finding. Okay, and this is occurring where at about 60 years of age, greater than 60 years of age, right? Affects the neurons contain. Affected neurons will contain what? Lewy bodies. And we will see in the Lewy body dementia that we will also see Lewy bodies. But here we have Lewy bodies, which will be seen in the affected neurons. Intracellular eosinophilic inclusion composed of high-yield alpha-synuclein. Looking at picture B, the mnemonic is think Parkinsonuclein or something. Parkinsonuclein. To remember synuclein with the Parkinsonism. Looking at picture B, what do we see? Well, we can see take a look at this. Here is the a proper eosinophilic. Eosinophilic means pink inclusions, which is composed of. So we have a pink inclusion, which is composed of alpha synuclein, Parkinsonuclein. That's the mnemonic. Okay, and that is going to be all for this guy. But here we also have progressive. You will also get progressive supranuclear palsy, Parkinson plus syndrome, which is clinical presentation is going to be TRAP, however you want to call it. TRAP features will be there, plus vertical gaze palsy and cognitive dysfunction associated with hummingbird sign on the midbrain MRI. On the midbrain MRI, human bird sign. And that is what we have for Parkinson. So with one more important point here is going to be your dementia, right? So dementia is late finding with Lewy bodies present there, right? In the neurons. So compare this with versus the Lewy body, which we will talk about, but here Lewy body dementia, which is dementia with the Lewy bodies present in the neurons. But the problem is with the Parkinson disease, the dementia is a late finding versus with the Lewy body dementia is an early finding. That's worth noting. Other than that, we have these Lewy body will be seen where, which neurons? We talked about it right here. We are substantia nigra pars compacta, which are mentioned, highlighted in this picture. This is substantia nigra pars compacta. Okay, and that is going to be all for Parkinson disease. Let's move on to the next. Okay, Huntington disease. Huntington disease, it is an autosomal dominant. Let's actually look at the here first. It is the Huntington disease. If you look at the areas, that is the, so here, what is this area? If you're calling putamen, then you're right. It is putamen. Putamen. The big guy over here is going to be putamen. What is under putamen? Globus pallidus. Globus pallidus, right? And what is just near the third, or the actually the lateral ventricles? That is the that is going to be your caudate nucleus. Can you recall when we say caudate and putamen all together? What is the structure that we call that structure something when we talk about caudate and putamen? This is caudate and this is putamen, and that is called striatum, right? So here we have a loss of GABAergic neuron where in the striatum, meaning caudate and putamen. It is an autosomal dominant trinucleotide repeat expansion, high yield. AD, autosomal dominant with trinucleotide CAG, CAG, repeat expansion in Huntington HTT gene on chromosome 4 letters. Okay, Hunt, right, 4 letters, which leads to toxic gain of function mutation. Okay, symptoms are typically manifest between age 30 to 50. I mean, sort of a adult, young adult, or just adult, right? Not an old age. Symptoms will present with chorea, athetosis, aggression, depression, dementia. Wow, take a look at all these. Aggression, a young adult with aggression, with depression, dementia, chorea, athetosis, Huntington disease. Sometimes initial be mistaken for what? Just the way I thought about it, substance abuse. Young adult, substance abuse, aggression, depression, but on top of that you have dementia, chorea, athetosis. So keep an eye out for substance use as a mistakenly diagnosis for Huntington disease. So now here we have the atrophy of the striatum. Okay, where did we go? Here. Atrophy of the striatum, which includes the caudate and putamen, which if you atrophy the structure, what's going to happen? Well, the ventricles will take up the place. So when the ventricles take up place, they will lead to ventromegaly, known as ex vacuo ventromegaly, because of the enlargement of the frontal horns of, specifically, if you think about specifically, there's going to be enlargement of frontal horns of lateral ventricle. Frontal horn. So if you just, let me actually draw it here. Something like this, right? So these are the frontal horns. These are the frontal horns of lateral ventricle. So enlargement of this, because you have the atrophy of these structures, so frontal horn will take up the place, and that's the causing ventromegaly, because you have messed up your dopaminergic neurons. You have a loss of dopaminergic neurons. I mean, not dopamine, my bad. Loss of GABAergic neurons. Your dopamine will increase. Your GABA, because you don't have GABA neurons, GABAergic neurons. Of course, the GABA is decreased. But on top of that, you also have acetylcholine, which is also decreased. Okay, neuronal death will occur via NMDA receptor binding and glutamate excitotoxicity. So there is a phenomenon that is known as glutamate excitotoxicity. Glutamate, let's talk about that here. So glutamate excitotoxicity, first you have to know the normal. Normally, so glutamate normally binds to NMDA receptors. Okay, this is very high yield. So glutamate normally binds NMDA receptors that leads to calcium influx. Okay. In case if you have increased in glutamate, in which case you would have increase in glutamate. For example, neuronal death. When you have a neuronal death, you have increase in glutamate, which is an excitotoxic, excitatory neurotransmitter. So here in Huntington, what are we causing? We are having a neuronal death. Neuronal death causing increased level of glutamate. But not only here. We will also have increased neuronal death. Not only occurs here, right? Where would you have a neuronal death? In your cerebral infarctions. You know, you're gonna have neuronal death. In that case scenario as well, you have increase in glutamate, and that increase in glutamate would also bind to their normal receptor, which is again NMDA receptor, right? And that leads to, because there are excess binding of that glutamate to all these receptors, now you can have excess calcium influx. That excess calcium influx will cause what? It will cause, simple wording, excitotoxicity. Excitotoxicity, right? Simple. That excitotoxicity itself, you're exciting exciting them so much that the cells will die, leading to cell death. They will lead to cell death. So let's take a look again, and then I'll tell you the treatment here. Neuronal death will cause what? Increase in glutamate that will bind NMDA receptor and cause excitotoxicity. And that excitotoxicity will cause cell death or neuronal death. Okay? And that is very high yield point. Now, how do you treat that? Well, so you already had, okay, think about one more time. Very high yield point. That the patient is in Huntington disease, or the patient is already in cerebral infarction. They're already causing neuronal death due to these factors themselves. But what you don't want to cause is more cell death due to increase in glutamate, right? So simple thing, you got to inhibit glutamate as a treatment. So what are the glutamate inhibitors, or where the glutamate X on? You want to inhibit that, NMDA, right? So what are the NMDA receptor inhibitors? So treatment is, let's just put it here, right here. Treatment is going to be NMDA receptor antagonists, which are going to be your high yield, which are your memantine, magnesium also, magnesium. So these things will inhibit NMDA receptors. So no matter how much glutamate you have, they will not act on that NMDA receptor, leading to no excitotoxicity, causing cell death. And that's all behind this neuronal death and all that. Now, the other important point is all about anticipation. Anticipation results from expansion of CAG repeats. And the CAG, they're saying, okay, how do we remember? Okay, Huntington has a CAG, trinucleotide repeat, and that is simple. It is the caudate loss, ACH. I mean, that's also decreased, and GABA is also decreased. So you can just think about all of them are lost or decreased, right? So caudate loss, ACH decreased, and GABA decreased for this CAG, trinucleotide repeat. What is anticipation now? Biochem. Anticipation is all about with the successive generations, that it's going to occur at more earlier age, with more extensive disease, or with more severe disease form. Okay, that is called anticipation. So again, anticipation is subsequent generations will have two things: early onset of disease, and more severe disease. That's called anticipation. Again, is in your biochem section, and that is going to be there. Okay, when there's a loss of GABA, so let's talk about GABA at the moment here, because the GABA is what is it? It's an inhibitory neurotransmitter, right? So inhibitory GABAergic neurons in the caudate neurons are more susceptible to damage. Caudate, they are more susceptible to damage. And GABA loss is responsible for manifestation of the Huntington disease symptoms, which is chorea, athetosis, behavioral disturbances. Okay, And that is going to be all for this one. Lastly, one last thing for the movement, right? So these patients, right, the movement would start with fidgety, restlessness, okay, at the initial stages, and that would progress to rigidity and akathisia. It will first you have again fidgety movements and restlessness, but progressively you're going to do some rigid or akathisia movement with the Huntington disease, and that's going to be all. In neuroimaging, one important point is neuroimaging will show you bilateral atrophy of the caudate, as you can see in this picture, bilateral atrophy of the caudate and putamen, and that is going to be all. Let's just quickly review this and move on to the next. We talked about Huntington disease being loss of GABAergic neuron. You got to know caudate putamen striatum. Caudate putamen striatum. Loss of GABAergic neurons. When you lose the GABAergic neurons, there's going to be decrease in GABA, of course, but there's an increase in dopamine, and there's a decrease in acetylcholine. The mnemonic here is also high yield CAG. CAG for trinucleotide CAG repeats, which are going to lead to anticipation of the disease. And because it's a hung HTT gene and chromosome 4 as a 4 letters hunt. Okay, symptoms, again, age is very important, 30 to 50, young sort of a patient. Substance use is there. Substance use as not there, my bad, it's mistaken for substance use because there are aggression, depression, dementia. On top of that, you have the two specific chorea and ethitosis. With the movement disorder, there's a progression from fidgety, restlessness, then progresses to rigidity and akathisia, and you have ventromegaly, specifically the frontal horns of the lateral ventricle. Even if you forget the frontal horns, just remember it is near where? It is near the lateral ventricle, right? So of course, the lateral ventricle is going to be the one which is going into enlargement, so ventromegaly. And that is all for Huntington. All right, now let's talk about dementia, which is going to lead to neurodegenerative diseases like Alzheimer's. So let's talk about the first definitions here. Dementia is a decline in cognitive ability. What is a cognitive ability? For example, memory, executive function. So when you have a decline in your cognitive ability, it's called dementia. With intact consciousness, for sure. Okay. Reversible cause of dementia include depression, high yield. It's called, sometimes depression is also called pseudo-dementia because it's a reversible cause of that dementia. Hypothyroidism, vitamin B12 deficiency, neurosyphilis, abnormal pressure, hydrocephalus. Okay. Now, in the neurodegenerative dementia, we have the disease known as Alzheimer's disease. One of the diseases is Alzheimer's disease. In Alzheimer's disease, it is the most common cause, high yield, most common cause of dementia in older adults. In older adults, most common. There's an advantage, advanced age is the strongest risk factors for Alzheimer's. So what are the risk factors? Advanced age, Down syndrome. Patients have increased risk of developing early onset Alzheimer's disease as that APP, which is amyloid precursor protein, is located on chromosome 21. With Down syndrome, you have it's a trisomy, so you will have 3 21s, right? It's a trisomy, so 321 chromosome copies will be there. So guess what? You're gonna have increased level of APPs. When you have increased level of APP, which is an amyloid precursor protein, there's increased propensity of Down syndrome patient to go into Alzheimer's at an earlier age. And that's exactly what's written up top. Earlier onset Alzheimer with Down syndrome, high yield. Why? Because you have on chromosome 21, you have APP. With Down syndrome, you have is a trisomy, 21 chromosome. 3 copies of 21 chromosome will be there and causing increased level of APP. Now, high yield point, there's going to be decrease in acetylcholine in the brain. Okay. So let's just look at the risk factors. We said advanced stage in Down syndrome. What are the associations? So association with the following altered proteins, for example, ApoE, E2 decreases the risk of sporadic form, whilst ApoE4 increases the sporadic form. So what are the sporadic form? Well, sporadic form occurs in this as you advance age. And the earlier form occurs with the Down syndrome, a young patient with Down syndrome. So sporadic, let's just write it here. Advanced age will give you sporadic Alzheimer's disease. And the earlier, there's another one, earlier form, which is earlier onset, which is seen in Down syndrome with the earlier age. Okay. Here, again, looking here, we have ApoE2 will decrease the risk of advanced age Alzheimer's disease. ApoE4 will increase the risk of that sporadic form, again, the advanced age. Then you have this APP, pre-senilin 1, pre-senilin 2, familial forms that are, again, they are 10% with the earlier onset. They are, again, all of these are the ones we talked about in earlier age Down syndrome. Okay, so here's the mnemonic. You have ApoE2 is pro-2 active or pro-2 active. ApoE4 is for Alzheimer's disease. Simple thing. 4 increasing as a higher number increases the risk of sporadic form. 2 is a lower number, would decrease the risk of sporadic form. Simple as that. And widespread. So what do you see in Alzheimer's disease? Well, before we talk about it, let's just take a look at one important factor. That is, how do we get this? Actually, they have talked about here, so we'll move on and talk about, first of all, widespread disease. So widespread cortical. So in Alzheimer's disease, we have a widespread. The whole sort of all of the cortex is going into atrophy, especially in the hippocampus, both sides, right? Narrowing of the gyri, high yield. You will have a narrowing of the gyri and widening of sulci. Because why? Because you have a cortical atrophy. When you have a cortical atrophy, you will have a narrowing of the gyri and widening of sulci, because the brain is going into atrophy. Now here, what you have is senile plaque. Senile plaque, high yield, that is picture A in gray matter. We'll look at that in a bit. What are senile plaques? They are extracellular amyloid beta core, may cause amyloid angiopathy, leading to intraparenchymal hemorrhage. A beta is derived from cleavage of APP. Now that's important. They're saying A beta is derived from APP, which is right here, amyloid precursor protein, right? So APP is giving rise to A beta amyloid, and that A beta amyloid is the core which causes this amyloid deposition, which causes senile plaques. So how do we get from APP? So does that mean all the APPs, we have normal 2 chromosomes, all of them have APP? Does that mean all of the APPs are going to go into, eventually are going to go into A beta amyloid? The answer is no. So what's the answer here? So the normal physiology here is that APP, which is present on chromosome 21, that will get cleaved into some, what is APP? First of all, APP is what? Amyloid precursor protein. Amyloid precursor protein. Okay. And this will go and get converted into, normally it's going to get converted into non-amyloid protein by 2 secretase. What are the 2 secretases? Alpha and gamma secretase. Important thing. APP gets destroyed into non-amyloid protein by alpha and gamma. But when the beta secretase works on the APP, it forms amyloid, A beta amyloid. And that amyloid gets deposited within the structures of the brain, and that causes Alzheimer's. Okay, and how? And because A beta amyloid is neurotoxic, it is neurotoxic, damages the brain, widespread damage. Okay, and that is the Alzheimer's disease. Again, let's just quickly look at it normally. So let's just have a normal color as blue. That APP is going to normally get into non-amyloid protein by the work of alpha and gamma secretase. Normal. Everything is normal. It's not an amyloid protein. It's not going to get deposited. That's the normal function. But if there's a beta secretase which works on this APP, which is amyloid precursor protein, it converts it into amyloid beta, amyloid beta, which is neurotoxic and which will cause widespread cortical atrophy, and also especially in the it starts with the hippocampus first, and that gets deposited in the brain, and that is seen in the Alzheimer's disease. With the advanced age, for sure you see that, and with the Down syndrome, it's not going to be advanced age, but earlier age, because you have more and more APPs now that is going to get into the A beta amyloid, and that's the pathophysiology behind Alzheimer's disease. Now, looking on the right side, we have neurofibrillary tangles. Again, we'll see that in picture B. They are intracellular. So let's just take a look what we talked about. We said senile plaques, they are extracellular, while the neurofibrillary tangles are intracellular, hyperphosphorylated tau protein. So tau protein being hyperphosphorylated, meaning so much phosphorylation is going on with the tau protein that forms it to an insoluble element. When it is insoluble, I mean, it's going to just be there, right? And it's going to cause the tangles and correlates with degree of dementia. The more you have tau proteins, which are just insoluble proteins, the more you're going to go into dementia. Antibodies are intracellular. Again, eosinophilic meaning pink. Proteinaceous rods in the hippocampus. That will also be seen here. So looking at this picture of hippocampus, this is hippocampus. Just above we have this, we have it amygdala, hypothalamus is there, thalamus is there, and you have the basal ganglia. Let's now take a look at the pictures, what we understand by it. So here's the picture. This is the senile plaques, which is extracellular. And the picture B, this is the neurofibrillary tangles, which are intracellular, tau protein, hyperphosphorylated, meaning so many phosphates there that are insoluble. Okay. Senile plaques, if you just take a look at these senile plaques and intracellular tau proteins, which are also known as neurofibrillary tangles. Antibodies is not here, but those are going to be just let's just imagine that this is hippocampus, and those are going to be your rod shape, a pink rod shape within the hippocampus. They are not known as antibodies. Okay. All right. What extra points that we might have are going to be that with these patients is going to be slow onset memory loss. So let me just write these points down here. So you have a widespread cortical atrophy, slow onset memory loss, widespread cortical atrophy. And that would cause narrowing of, due to the fact that you have the narrowing of the gyri and widening of the sulci with the atrophy, right? But on top of that, there's another thing. When there's this atrophy of the whole cortex, right? That's the whole cortex, the space will be somewhat taken up by, with the ventricles, right? So ventricles would enlarge, and that will also lead to hydrocephalus ex vacuo. We will talk about that, but that's going to be hydrocephalus ex vacuo because of all that ventromegaly. That is going to be there. And what else we can think about? One more thing is here with the decrease in acetylcholine, right? Decrease in acetylcholine where? We talked about Alzheimer's disease being the hippocampus, right here, being the hippocampus, being the primary area, and also the so it is going to be decrease in the hippocampus, decrease acetylcholine in hippocampus, plus, if you recall, the acetylcholine is coming from where? If you are thinking the Maynard, the nucleus of Maynard, which is the nucleus basalis of Maynard, yes. So there's going to be destruction in the nucleus basalis of Maynard, which was producing acetylcholine. Now that's where we have low acetylcholine. And that decrease in acetylcholine, so whatever the acetylcholine we have left, so let's talk about a little bit of treatment point here. And worth mentioning one more point here before the treatment is going to be your, again, glutamate. Glutamate, what was that causing? Well, glutamate, wherever we have some neuronal death, there is going to be increasing glutamate. Here we have the whole cardiac atrophy. Of course, we're going to have increasing glutamate, right? That excess glutamate will cause NMDA excitotoxicity. That NMDA excitotoxicity will cause what? Increase in calcium, influx. And with that increase in calcium influx, you have all you got to think about in Alzheimer, there's going to be increase in, again, APPs, which is going to be increased production of amyloid precursor proteins. Amyloid precursor proteins. And that is also problematic because eventually that's going to cause what? The beta secretase will work on it, forming again more and more amyloid beta that will just deposit and cause more and more destruction. So the treatment options are going to be you have to stop this guy so that you're not making any more APPs. So to stop it, you got to give with drugs, NMDA receptor antagonisms, again, which are your memantine, or your magnesium, right? But on top of this, we said we have low acetylcholine. So we have a low acetylcholine. So what the one thing we can do is we can whatever low acetylcholine, we didn't say we have deficiency of acetylcholine. We said we have a low acetylcholine. So whatever we have acetylcholine, we don't want to get it degraded by the normal mechanism, which are your cholinesterase. So if you recall, from the presynaptic terminal, acetylcholine goes into the postsynaptic terminal. Within this synaptic cleft, acetylcholine gets degraded by cholinesterase enzymes. So what we want to do is we want to give cholinesterase inhibitors. So whatever acetylcholine is there will work on their receptors and do their normal action. So the drugs that we can give are going to be for systematic treatment. We can give cholinesterase inhibitors. So again, treatment options, two things, and we will talk about that more in detail in pharmacology. But here is just which makes common sense here. We want to give cholinesterase inhibitors to increase the level of acetylcholine, whatever we have left over, right? And the second thing is we don't want more destruction, so we want to give NMDA receptor antagonism. And a high yield important point is going to be that with that NMDA receptor antagonism, you're trying to do what? You're trying to decrease the disease progression. Because as I said, you increase APP, you're causing more and more damage. You want to stop this damage, you are going to decrease the progression of disease. Okay, and let's also look at one more last thing. What was APP? APP was normally, it's a gene that encodes for transaminases, transaminase proteins found throughout the body, okay? And cleavage of this protein inappropriately, when you cleave this protein inappropriately, that's seen by beta secretase, will lead to formation of A beta amyloids. Okay, and with this, let's just take a look at a couple of important features. Senile plaque, this is just a summary now. Senile plaque, it is an extracellular A beta amyloid core, may cause amyloid angiopathy. So when you have this A beta amyloid close to or nearby an artery, what's going to happen is they will deposit nearby artery, causing damage to that artery, leading to intraparenchymal hemorrhage. Okay. And neurofibrillary tangles, which are just tau proteins, which are insoluble, present there. They are the ones which lead to dementia because they're insoluble, remain there. Hiranobodies, the way we can think about hiranobodies, let me just erase this. Hiranobodies are going to be hiranorods. Where the problem started from hippocampus. In hippocampus, O's, all the O's, right? Hiranorods, hippocampus. I mean, you can just somehow put in the head, and that's going to be all for Alzheimer's disease. All right, now let's talk about frontotemporal dementia. Frontotemporal dementia is formally known as PIC disease. Early changes in personality, because you're technically temporal, right? Personality changes would be personality and behavioral variant, or aphasia. Primary progressive aphasia will be seen. May have associated movement disorders. Okay. Frontal and or temporal lobe atrophy, for sure. As the name suggests, frontotemporal dementia, you have atrophy, right? Inclusions of hyperphosphated. Again, look at this important thing. Hyperphosphated tau proteins, which are round PIC bodies. PIC's disease, PIC bodies. Picture C, are ubiquinated TDP43. Let's take a look at picture C here. Picture C, we see something as PIC bodies. Take a look at these PIC bodies. Tau PIC bodies, okay? Something that you see over there. Now let's take a look at what do we see? What are this associated with? So we know that we have a prefrontal cortex because it's a frontal and temporal, right? So if you recall, we have a prefrontal cortex. If there is an atrophy, because we said here is going to be atrophy, so prefrontal cortex atrophy will be seen, and that is going to cause all of the frontal lobe, whatever the frontal lobe does normally, there's going to be abnormality and all that. So what are those? There's going to be disinhibition, apathy, social inappropriateness, compulsive behavior, impaired judgment, poor problem solving skills, all due to the fact that you have the frontal lobe atrophied, and that is your behavioral variant with all of these behavior problems. Okay. And on top of that, you have aphasia. So aphasia is what? Altered speech, language. Altered speech. Okay. This is going to be the changes that you will see. But on top of that, later changes, later on, you will have, later changes are going to be global dementia and neurocognitive deficits. So dementia globally and neurocognitive deficits will be seen. And the earlier changes being in the prefrontal cortex, just changing in the personality and behavior. Later changes are going to be your dementia and neurocognitive deficits. Okay, and that is going to be all for this. Just to recall this whole thing, it's all about atrophy of the frontal temporal. Dementia is dementia, but this is seen in later on. Earlier on, you will just see personality, behavior, and aphasia because you're messing up the frontal lobe itself. Okay, you will see inclusions of, again, hyperphosphated tau, which are round PIC bodies. Round PIC bodies are seen just like round PIC bodies. You can see this. Round PIC bodies. Okay, and or ubiquinated TDP43, and that is going to be all for frontotemporal dementia. Okay, now let's talk about the second thing here. It's called Lewy body dementia. In Lewy body dementia, just on top of the head, you just have to know you have the Parkinson's side of features plus dementia. So let's talk about it. We have visual hallucinations, hallucinations, plus dementia with fluctuating cognitive, alertness, REM sleep behavior disorder, and Parkinsonism. Intracellular Lewy bodies, primarily in the context called Lewy body dementia, if cognitive and motor symptoms. Again, when do we call Lewy body dementia? When we have a cognitive plus motor symptoms, onset less than 1 year apart. Otherwise, so if you have a motor problems, again, what are the motor problems? Anything with the motor problems being there, right? Let's just talk about those motor problems that are, so all the Parkinsonism, like for example, rigidity, akathisia, all of that traps sort of a motor problem. When you have that, plus you have dementia within a year apart, onset, again, look at this wording, very high yield. Onset is less than 1 year apart, that you have dementia plus motor symptoms. Within a year, you develop all of it. That's going to call Lewy body dementia. The other thing we talk about in Parkinsonism is that with Lewy body dementia, you're going to have early onset dementia. So exactly what we have. We will have a dementia right away within 1 year. But if it is more than 1 year, that is going to be due to the fact that you have Parkinson's disease. So look, it says, consider dementia secondary to Parkinson's disease if they're not 1 year apart. If they're more than 1 year apart, you call it Parkinsonism causing dementia. If there are motor symptoms plus dementia, but within less than 1 year, you call it Lewy body dementia. And what are the Lewy bodies? Lewy bodies have specific characteristics. They are eosinophilic inclusion within the neuron. Again, they're like pink inclusions within a neuron, primarily in the cortex, in all cortex, and that is what we have. And that's going to be all for it. And let's move on to the next one. Now let's take a look at vascular dementia. Vascular dementia, it's second most common cause of dementia in adults, result of a multiple arterial infarcts. So you have a multiple arterial infarcts or chronic ischemia causing vascular. See, what are these? This artery infarct or ischemia, messing up the vascularization, blood, causing dementia. Second most common cause. It is a stepwise decline, of course, stepwise progressive decline in cognitive ability with late onset memory impairment. With the MRI or CT would show, again, this thing right here, which is multiple cortical and subcortical infarcts. Picture D, let's take a look. You have multiple cortical, look at this, multiple cortical, subcortical infarcts are there. And that is vascular dementia. Simple thing. So recalling the whole thing, vascular dementia, it's the second most common cause of dementia due to a lot of infarcts or ischemia. That's why I name as vascular dementia. And it's going to show high yield point that you will see multiple cortical infarcts and or subcortical infarcts. So multiple infarcts will be seen on MRI or CT. And that is all for vascular. Let's talk about the next one, which is going to be Creutzfeldt-Jakob disease. Now, Creutzfeldt-Jakob disease, it's a rapidly progressive. Okay, one more thing here. So we were talking about what? We were talking about let me just erase all this first. We were talking about neurodegenerative diseases, right? Neurodegenerative diseases. And in neurodegenerative diseases, we have Alzheimer's, we have frontal temporal Lewy body. Now we have vascular dementia, in which we have the vascular dementia. Now we're talking about infective dementia. That is where we have Creutzfeldt-Jakob disease. Now Creutzfeldt's and infective means this is Creutzfeldt's, and the next one is going to be HIV dementia. So infective dementias are Creutzfeldt-Jakob disease, which is rapid progressive, weeks to month dementia with myoclonus, which is startle myoclonus. We talked about it. Startle myoclonus will be seen where? With the Creutzfeldt Creutzfeldt-Jakob disease. And ataxia will also be seen. So dementia plus myoclonus plus ataxia, it is fatal. It is caused by prions, high yield. Prions, PRPC, forming PRP-SC, which is what? Which is a beta plated sheet, resistant to proteases. So when there's an accumulation of PRPSC, which is the prions, this accumulates, which accumulation leads to cell death. And this is the beta plated sheet, which are resistant to proteases. Proteases would not be able to degrade this, hence leading to accumulation and hence causing cell death. Okay, typically it is sporadic, but maybe transmitted by contaminated materials like corneal transplant, neurological equipment. Okay, now importantly, you have a spongiform cortex. Spongiform cortex vacuolation without inflammation. Let's take a look at picture E. So if you take a look at this picture E, what do you see? We see a lot of vacuolations. A lot of vacuolations, but without any inflammation. That's exactly what's going to be written there. Vacuolations without any inflammation or inflammatory cells. It is associated with periodic sharp wave complexes on EEG and increase in 14-3-3 protein in CSF. Okay. So with let's add some more extra high yield points. So spongiform cortex we will have vacuolization without inflammation, high yield point, right? But on top of that, that vacuolization is going to be throughout that gray matter. And neuronal loss will be seen due to that vacuolization. And I mean, you are having a vacuole for sure. You're having a neuronal loss, right? That will be seen as gliosis. Other name would be like gliosis is seen. Gliosis with cyst formation. That is going to be there. With the prions, what are the, so here, let's talk about this thing. With the prion disease, right? It could be, let's just erase little points here. As I said, it is typically sporadic, but could be transmitted by materials. So sporadic could be inherited, or iatrogenic. Iatrogenic being introduced in via the corneal transplant neurosurgical equipment. Okay, but there are other types of this prion disease, and those prions can also get in ritual cannibalistic practices. And when they're introduced via ritual cannibalistic practices, they are called kuru plaques. Kuru plaques because we have these extracellular prions accumulation which stain positive. Now this is important. Which stain positive for Congo red and periodic acid skiff stain. So if there is a question which is they're saying, okay, you have dementia, infective sort of dementia, and that's whatever the material is, it's Congo red or PAS positive, you're going to think about Creutzfeldt-Jakob disease, otherwise known as prion disease. Okay, and characteristically, you're going to have dementia, you will have myoclonus, and you will have ataxia. Three things: dementia, myoclonus, ataxia. So look, if the way you're going to think about it is as right here, three words, right? Creutzfeldt-Jakob disease, three things: dementia, myoclonus, ataxia. We're talking about whole spectrum dementia here, so of course dementia is going to be there. Two things extra are myoclonus and ataxia. And again, what is myoclonus? Myoclonus is just your startle myoclonus is all about your involuntary jerky movement of the extremity. Involuntary jerky movements of extremities, myoclonus. Okay, and with this accumulation, it's very high yield. That this normally the prions are alpha helix structure, which are degraded by proteases. But when you make them beta plated sheets, they are resistant to proteases, so hence accumulation, hence causing neuronal cell death as they're neurotoxic. Okay, and that is all for Creutzfeldt-Jakob disease. Okay, now let's talk about HIV associated dementia. With HIV associated dementia, we will see subcortical dysfunction associated with advanced HIV infection. It is characterized by cognitive deficits, gait disturbances, irritability, depressed mood. And what is advanced HIV? When CD4 count is less than 200. So we will see HIV associated dementia when CD4 count is less than 200. Okay. We will see diffuse gray matter and subcortex atrophied. We will also see myoglial nodules with multinucleated giant cells, and that is characteristic. When we have myoglial nodules, which in other words it is like cluster of myoglial cells around a necrosis, and they fuse together to form around a necrosis, and they will fuse, these myoglial cells will fuse and they will form multinucleated giant cells. And these multinucleated giant cells, these are the main culprits now, because they are going to release neurotoxins, which will have the subcortical destruction, causing subcortical atrophy. Okay, because if you recall, HIV replicates within the macrophages, right? And that's how you have the, first of all, the microglia, which are the macrophages. Nodules take cluster around the necrosis, then eventually forming a multinucleated giant cells, which lead to subcortical atrophy. So these patients are going to present with, again, because they're HIV. So HIV patient coming with dementia, and the memory deficit, like attention, memory deficit, executive dysfunction, and slow information processing. This is all due to the fact that they have subcortical atrophy. So subcortical atrophy causing what? Three things: attention, memory deficits, executive dysfunction, and slow information processing in advanced HIV diseases. Okay, that is going to be all for this, all the dementias.